You say. Hi students, welcome to the platform. I'm Dr. Ramya, your Obgyn Guru. So in this video, I'm going to have a quick recap of entire OBS. So you know your exam is near and I know how tense this time period is. So you can sit back and relax and revise entire OBS along with me in this video. So the video will run for around 3 to 3.5 hours. Okay? Right. So Urvi, the video might run for 3 to 3.5 hours. So you can sit back, relax, and try to understand as well as revise the entire OBS in a crisp manner with me in this video. Okay? So let us start with the video. So I hope I'm audible and visible to all of you. Okay. So, right. So first I'm starting with a very important ultrasound, which might come in your exam. So this is called as double decidual sign. So this last 5 days, it's very crucial, and most of the time we get tense to, you know, how do we manage this last 5 days of our preparation and all. So it's very simple. You have to just be peaceful and calm in this last 5 days. How peaceful and how calm you are in this last 5 days will decide your success. So just relax. Don't read anything new. Whatever possible, if you want to listen, you can listen, or whatever mistakes you have done previously, or any book if you have where you thought to decide what you have to do in this last 5 days, those are the things which are best to be done. And to cope up with the stress during this time period, breathing, deep breathing will help, or you know, sometimes even the square breathing helps. Yeah, the last 4 days, I know it's very crucial. So mentally, how stable you are in this last 4 days will depend how better you're going to perform in the exam. So you have all read very well, you have given your best. So mentally trying to keep yourself calm is the most important during this period. So just stay away from any negative people, just be in a positive aura, do either prayer or you know, meditation, all that helps. Okay, let us start. So try answering along with me throughout the PD, throughout the session. So where do we see double decidual sign? So double decidual sign is mainly seen in. So this is the gestational sac. Around the gestational sac, you'll have two rings. Can you see a 1, 2? So when a gestational sac is covered by two rings, that is called as double decidual sign. So this double decidual sign is mainly seen with the Decidia capsularis and Decidia paritalis. Decidia capsularis plus Decidia paritalis. So you can remember double decidual sign with the mnemonic of capsularis and paritalis. Now, this is also something related to double, guys. So what is this? So this is the entire gestational sac. So this is 1, this is 2. So this is yolk sac and amniotic sac. What do you call this as? This is called as double bleb sign. So double bleb sign is amniotic sac plus yolk sac. Okay. So this is double bleb sign. Double bleb sign is amniotic sac and yolk sac. So this is double bubble sign. This is double decidual sign, which is Decidia capsularis and Decidia paritalis. This is double bleb sign, which is amniotic sac and yolk sac. What is double bubble sign, guys? Where do we see double bubble sign? Anybody? So double bubble sign is seen in Down syndrome. Double bubble sign is seen in Down syndrome. Okay. Right. Let's go to the next one now. So there are different types of placentas. When one, yes, excellent. Double bubble sign is seen in Down syndrome, especially due to what? Due to duodenal atresia. Duodenal atresia. So baby with duodenal atresia, which is mainly seen in Down syndrome, will present you with double bubble sign. Correct. Excellent, Sanjay. Yes, this is succenturate. Very good, Dilip. So when one cotyledon is separate from the entire placenta and not connected, this you call it as succenturate lobe. Yes. See, if you are able to answer this much, more than enough. You're able to identify it, right? What is this? Now, what is the difference between the previous picture and this picture? Previous picture mein, the entire placenta mein only one cotyledon was separate from the entire placenta. When one cotyledon is separate from the entire placenta, it is called succenturate. When one placenta is divided into two, then we call it as very good. This is called as bilobed placenta. Bilobed placenta. Excellent, excellent, very good. Now, this is the most important which you got in the last exam. So last NEET May, they kept this image along with succenturate. So when cord is present attached to membranes, yes, this is called as membranous or filamentous. Both. It has two names. It is called both membranous and filamentous. So in membranous or filamentous, the vessels are present in the membranes. So this carries a very high risk of fetal hemorrhage because the membranes are not well supported by the Wharton's jelly. So this has risk of fetal hemorrhage. So we have membranous or filamentous, and this has the risk of fetal hemorrhage. Okay. Right. Next is when this, yes, this is vasa previa. When placenta, when membrane, when cord is attached to the membranes and that membranes with vessels overlie the internal os, then you call it as vasa previa. So vasa previa is vessels with membranes overlie the internal os. So vasa previa is vessels with membranes overlie the internal os. So see, this is the vasa previa. Can you see here? The cord is attached to the membranes. Okay, this can be due to succenturate lobe. This can be due to bilobeta. And this can be due to filamentous. You should not do PV here. You should not do PV here. Per speculum and PV is not allowed. So they can present you with painless bleeding. What will the MCQ present to you is that there is sudden decrease in the fetal heart rate once the membranes have ruptured. So whenever there is sudden decrease in the fetal heart rate when membranes rupture, it is nothing but the vasa previa. So vasa previa, there is sudden decrease in the fetal heart rate once there is rupture of the fetal membranes. Okay, now tell me one thing. If you do PV, what is the feel which you are going to have? You will have bag of worms. See, because these vessels are there. Both for cord presentation, when umbilical cord is present over the cervix, that is called cord presentation. In cord presentation also, you'll have bag of worms feel. In God presentation also, you'll have bag of worms feel. Okay? So, vessels with membranes overlie the internal os. Here we can have it as succenturate, bilobeta or filamentous. Investigation of choice is TVS with Doppler. Management is elective cesarean section at 36 to 37 weeks. 36 to 37 weeks. Right? Now, if there is cord presentation, if there is a cord presentation. So umbilical cord will come out. If there is a cord presentation, then umbilical cord will come out, right? So when the umbilical cord comes out, that we call it as cord prolapse. For cord presentation also, you'll do LSCS itself, cesarean, lower segment cesarean section, and never do PS and PE. And if there is a cord prolapse, one important point which you know and which has been asked as an MCQ is never touch the cord. Never touch the cord. See, I'm trying to cover your PYQs. So never touch the cord when there is a cord prolapse. You can either put her in Trendelberg position or and shift her to the OT. Okay, now, what is this, guys? What is this? What is this? So this is placenta previa. When placenta is lying over or near the os, then we call it as placenta previa. We have 4 types. Type 1 is called low lying, where placenta is within 2 centimeters from the internal os. Right? So type 2 is marginal. It is just touching the margin of the os. So type 2 is marginal, where it touches the just margin of the os. Type 3 is partial. Type 4 is total. So this totally covers the os. So type 1 is placenta is within the 2 centimeters from the os. Type 2 is marginal, which just touches the margin of the os. Type 3 is partially covering the os. Type 4 is totally covering the os. Okay. So type 2B, type 2 may posterior. This is called dangerous placenta previa. So type 2B is called as dangerous placenta previa. So now what is this? This is called abruption. So abruption may, there is premature separation of normally situated placenta. So the menstrual blood seeps out. There are 2 types of abruption, guys. There are 2 types of abruption. So once the placenta gets separated and all the blood comes out, that is called as revealed abruption, like in this picture. When the placenta gets separated and the blood seeps inside, what do you call that as? Concealed. And you can also have mixed. I want you people to tell me which is the most dangerous among these 3. See, revealed may, she'll immediately come to you as soon as there is a bleeding. Concealed may, she'll not come to you unless until there is a significant pain abdomen, right? So concealed is the most dangerous. Very good, Rubik. Concealed is the most dangerous. Yes, excellent, Dilip, Divya. Very good. Concealed is the most dangerous. Concealed may, pallor will be out of proportion to bleeding. Concealed may, pallor will be out of proportion to bleeding. Concealed may, uterus will be more than period of gestation. Can you palpate the fetal parts? No, uterus will be tense, tender, and you cannot palpate the fetal parts. So pallor is out of proportion to the bleeding. Uterus will be more than period of gestation, and uterus will be tense, tender, and fetal parts are not palpable, right? So concealed is the most dangerous. Okay. And concealed may, what is that uterus? In concealed may, what is that uterus? Where the blood seeps into the uterus, what do you call that uterus as? So you call it as covalar uterus. Covalar uterus. Now we will see some differentiating features between the abruption and placenta previa. So placenta previa will have painless and profuse bleeding. Abruptio will be painful. Most important point for your MCQ purpose is what type of bleed. So by the type of nature of the bleed, you can differentiate. And these MCQs, I feel definitely they'll come based on the antepartum hemorrhage. So please remember, vasa previa is also painless bleeding. Previa means painless. Placenta previa is also painless bleeding. Abruptio is painful. So placenta previa is painless and profuse. Abruptio is painful. Placenta previa mein bleeding is always revealed. Abruptio mein it can be revealed, concealed or mixed. Placenta previa mein there will be periodic bleeding. So to, intermittently she'll go on having bleeding, intermittent episodes of bleeding. Abruptio mein it will be progressive. Placenta previa mein it will be proportional to the pallor will be proportional to how much ever blood loss is there. Abruptio may out of proportion to the visible blood loss, especially in the concealed and mixed variety. Most of the abruptions are underlying pre-eclampsia or hypertension. Most of the abruptions have hypertension in the history. Remember this point. So pre-eclampsia likely to be present, absent here. Uterus can be more in concealed. Uterus will be equal. Uterus is soft and relaxed in placenta previa. Uterus is tonically contracted in abruption. Head is engaged. Malpresentations are common in placenta previa. What is that sign in placenta previa? When you push the fetus into the pelvis, baby hits the placenta and there will be decrease in the fetal heart rate. What is that sign called as? So it is called as Stahl-Worthy sign. Stahl-Worthy sign. So placenta previa and placenta will be in the lower segment. There it will be in the upper segment, right? Tocolysis can be given, but tocolysis is never given in the placenta abruption, right? So here LSCS or vaginal delivery. DIC is more common in abruption. DIC is more common in abruption, less common in placenta previa. Indeed, the most common cause of DIC in pregnancy is abruption. The most common cause of DIC in pregnancy is abruption. Okay. Now, more delivery for placenta previa before 37 weeks, you can wait and watch. If mother is hemodynamically stable, there is no fetal distress, you can wait and watch. And wait and watch in placenta previa is called as, what is the name? McAfee and Johnson's regimen. McAfee and Johnson's regimen. So conservative management in placenta previa is called as McAfee and Johnson's regimen, right? Stahl-Worthy sign is whenever you push the fetus into the pelvis, there will be decrease in the fetal heart rate. Whenever you push the fetus into the pelvis, see, placenta is down. So when you push the baby into the pelvis, baby will go hit the placenta and decrease the fetal heart rate. That is called Stahl-Worthy sign. So placenta previa mein less than 37 weeks, it's called McAfee and Johnson's regimen. More than 37 weeks, you can go for LSCS. There is no vaginal delivery in placenta previa. Just remember LSCS. Abruptio management, I want you to understand very well, guys. Abruptio management, I want you to understand very well. So abruptio mein, abruption mein, you check for the fetal status. If fetus is alive and if there is fetal distress, then you'll go for LSCS. Wherever there is distress, always LSCS only, no? When fetus is alive and when there is no fetal distress, you can do ARM and try for vaginal delivery. If baby is dead, then check the maternal status. Check maternal status. If mother is having DIC, first correct DIC. And then you go for vaginal delivery. If there is no DIC, then directly vaginal delivery. So if mother is having DIC, first you correct the DIC and then go for vaginal delivery. If there is no DIC, directly go for vaginal delivery. Okay? So basically in abruption, everywhere it is vaginal delivery except when there is a fetal distress. Now that's about the abruption and a placenta previa. Try to read this question and try to answer, guys. 36 weeks pregnant woman came with the complaints of bleeding for vaginum associated with pain. So when there is an associated pain, is it abruption or is it placenta previa? Is it abruption or is it placenta previa? FHR is absent and uterus is tender. Baby is dead. What is the diagnosis and management? Very good. Excellent, Rubik. Very good. It is an abruption. It's abruption. So why is it abruption? Because we are having the... Why is this abruption? Because we are having painful vaginal bleeding. Painful vaginal bleeding, right? So this is definitely abruption. Excellent. As the baby is already dead, you should better go for vaginal delivery. I appreciate. All of you have answered correct. Answer A is correct. Correct, 100%. Now, please answer this question. A lady with 35 weeks of pregnancy presents with bleeding for vagina. Investigation shows severe degree of placenta previa. The treatment is... Immediate cesarean section, blood transfusion conservation. See, she's 35 weeks, yeah. She's 35 weeks. 35 weeks, I told you what? Less than 35 weeks, less than 37 weeks, I told you conservative, no? She's having severe degree of placenta previa. They didn't tell it is severe placenta previa. It is just severe degree of placenta previa. It's not severe placenta previa. So you can wait and watch on her. That is McAfee and Johnson's regimen. So C is the answer here. Conservative is the answer here. Very good, Dr. Rubik. C will be the answer here. You understood? C, placenta previa may up to 37 weeks, wait and watch. That is McAfee and Johnson's. Beyond 37 weeks, it is LSCS. As she's only 35 weeks, and she has severe degree of placenta previa, you're going to go for conservative management. Morbidly adherent placenta. Why do we see morbidly adherent placenta? So morbidly adherent placenta is mainly due to absence of Abruptio fibrinoid layer. Or it is also due to absence of Decidia basalis. See, guys, I'm going to revise the entire subject in such a way that, like, if you're my study partner and we both are revising this entire obs, how can we revise in 4 hours touching every topic? That will be the main motto of this session. Okay? So we are going to revise it in such a way that, like, just revision. एक point नहीं revise करेंगे. जो important है, जैसे हमें याद आना चाहिए, वैसे हम revise करेंगे. ठीक है? तो morbidly adherent बोलेंगे, तो what is the immediate point which will strike your brain? It is mainly due to absence of Abruptio fibrinoid layer या Decidia basalis. 3 टाइप है इसमें. अक्रीटा है, इंक्रीटा है, परक्रीटा है. अक्रीटा, A for अक्रीटा, A for adherent to the myometrium. Adherent to the myometrium. Now tell me one thing. This morbidly adherent placenta is also called PS, placenta accreta syndrome. I tells invades myometrium. Percreta penetrates myometrium to reach perimetrium. Penetrates myometrium to reach perimetrium. So accreta is adherent to the myometrium. Increta is invades myometrium. Percreta penetrates myometrium to reach the perimetrium. Percreta penetrates the myometrium to reach the perimetrium. Percreta can also go up to the bladder. Percreta can also go up to the bladder. Right? Percreta can also go up to the... Why do we have this morbidly adherent placenta? So any trauma to the uterine wall can cause previous DNC, previous LSCS, previous scars. So any trauma to uterine wall. What will be the treatment? Diagnosis is by USG. It can cause retained placenta and retained placenta and PPH. So treatment, you will do elective cesarean section again. So here we'll do classical cesarean section. Then what will you do? Fetal extraction, followed by cesarean hysterectomy. So we'll do classical cesarean section, followed by fetal extraction, followed by cesarean hysterectomy. Okay. So that is the morbidly adherent syndrome or placenta accreta syndrome ka management. Okay. Now, if she is a primary and she want to conserve the uterus, only there I will leave the uterus behind and I remove only the loosely adherent placenta. But rest everywhere, I'll go for classical cesarean section, fetal extraction, followed by cesarean hysterectomy. Right? Next. All of the following can be used to determine the expected date of delivery in an IVF pregnancy, except. So can you tell me what should be the answer for this? See, whenever we are having an IVF pregnancy, so normally from the day of ovulation, yes, excellent. So from LMP plus 9 months plus 7 days won't work. LMP 9 months plus 7 days is Naegeli's formulas, which is mainly used when patients have regular cycles. When patient have regular cycles. So if a patient has IVF cycle, you can do from the day of oocyte retrieval plus 266 days. From day 3 embryo transfer, 263 days. From day 5 embryo transfer, 261 days. Okay. Naegeli's won't help in determining the EDD in IVF pregnancies, right? So first 3 are for the IVF pregnancy. When they have regular LMP, then we'll go for Naegeli's formula. So that is for 28 days cycle. Okay, one more thing you tell me. If somebody has 32 days cycle and LMP is 11th June, when will be her EDD? Yes. So if to add 11 days, so that is 22 minus March 25. So you have to add same 9 months plus 7 days plus 4 days extra, because from 28 days, it is 32 days. Okay. Yes. So it will be 22nd March. How much ever maths I know. 7 plus 4, 11. 11 plus 11, 22. It will be 22, no, Dilip? For irregular cycles and when they missed pills and conceived, there we can go for ultrasound. On USG, first trimester, you mainly measure the crown rump length from the crown to the rump. So crown rump length is the most accurate on USG. So crown rump length plus or minus 7 days, it will give EDD. Biparietal diameter will give you plus or minus 2 weeks difference. Femoral length will give you plus or minus 3 weeks difference. Okay. See here, 11th June I told. So you have to do plus 9 months from the June. That is March. You should ideally do only 7 days for a 28 days cycle. जितना दिन 28 से ज्यादा है उतना दिन एक्स्ट्रा ऐड करना पड़ेगा, क्योंकि उसका 32 डेज साइकिल है. आप क्या कर रहे हो, 7 को अनदर 4 डेज ऐड कर रहे हो. सो 11 + 11 22. अंडरस्टूड. So third trimester scan is not at all useful for estimating the fetal weight. Third trimester scan is mainly useful for interval or growth scan. Interval or growth scan. Okay. Right. So please tell me about gravida and para. You know, gravida, para, you tend to get a question and we so many times we don't answer it. Uncle, door closed in kitchen. So what does, till you answer this question, I'll tell you, gravida means total number of pregnancies irrespective of the outcome. Gravida means total number of pregnancies irrespective of the outcome. It also includes the current pregnancy. जितने बार बच्चे होते हैं इस प्रेगनेंसी को इंक्लूड करके उसको ग्रेविडा कहा जाता है. पैरा मतलब all those pregnancies which have crossed the period of viability. It does not include the current pregnancy. It does not include the current pregnancy. For twins, gravida and para are one only because it is 9 months pregnancy. But for twins, the outcome will be 2. That's the simple thing. Okay. So what is the answer for this, guys? A mid-aged woman came to the OPD with a twin pregnancy. She already had 2 first trimester abortions. She has a 3-year-old female child who was born at the end of 9th month of gestation. Which of the following is her accurate representation? So she got pregnant how many times? She already has 1 twins. She has 2 abortions and she has 1 3-year-old female child. So totally how many times she got pregnant? She got pregnant around 4 times, right? So that's why it will be G4. How many pregnancies cross the period of viability? Only 1 pregnancy, para 1, living 1 and abortion 2. So it is C. Yes, Rahman, correct. For 26-day cycle, from the formula, you have to reduce 2 number. That's all. Okay. So preterm means any delivery which take place before 37 weeks is called as preterm. Any deliveries that take place between 37 to 42 weeks is called term. In term, you again have a division. 37 to 38 weeks is called early term. 39 to 40 plus 6 weeks is called term. Late term is 41 to 42 weeks. Right? What is post-term? Beyond 42 weeks. What is post-datism? Beyond 40 weeks. Post-term is beyond 42 weeks. Post-datism is beyond 40 weeks. So preterm labor is any pregnancy before 37 weeks. The early preterm is before 34 weeks. Before 34 weeks is bad. So what is the diagnostic criteria for the preterm labor? So the diagnostic criteria for the preterm labor is when they have 8 contractions in 10 minutes or 4 contractions. When they have 8 contractions in 60 minutes or 4 contractions in 20 minutes. This has been asked in the question in the NEET, the criteria, guys. 8 contractions in 60 minutes and 4 contractions in 20 minutes. Plus, cervix is 2 centimeter dilated and 80% effaced, 80 to 90% effaced. Then we call it as preterm labor, established preterm labor. Predictor, cervical length less than 2.5. Yeah, fetal fibronectin, which is a fibrin glue which adheres the amnion to chorion. How do you prevent this? So you prevent this by giving progesterone and cerclage. Guys, what is the most commonly done cerclage? What is the most commonly done cerclage? See, my main motto from this video is I have to cover most of the MCQs, most of the MCQs. That's the main motto, right? So what is the most common cerclage? It is McDonald cerclage. Whenever McDonald fails, we go for McDonald is a pursue string cerclage. But whenever McDonald fails, we go for something called as modified Shirodkar cerclage. One of the PYQ which you got was, what is the cerclage which you put in the inter-pregnancy interval? What is the cerclage which you put in the inter-pregnancy interval? So inter-pregnancy interval में inter-pregnancy interval मतलब we know that there is a cervical incompetence for this patient. In this pregnancy, I'm not putting a stitch. I'm putting a stitch in the next, before the next abortion. In between the two abortions, inter-pregnancy interval में. So inter-pregnancy interval, if you're doing laparoscopic, it is, you can do laparoscopic, that is abdominal route, or if you're doing vaginal, it is lash and lash, lash and lash. Emergency cerclage, when cervix is already dilated more than 4 centimeters, if you put a stitch, that is called as worm cerclage. Worm cerclage, WURMS, worm cerclage. So when you put a stitch before, when cervix is already dilated, it is called worm cerclage. जहां पे आप अगर 3 पे जा रहे हो, 3 to 9 o'clock and back to 3, 12 to 6 o'clock and back to 12. This is called as worm cerclage, which is an emergency cerclage. Okay, done? Chalo, let's go back here. What is the management of preterm labor? What is the management of preterm labor? There's only difference between preterm labor management and PROM management. What is PROM? Premature rupture of membranes. Premature rupture of membranes. Preterm labor and PROM, the only difference is whether to give antibiotics or not to give antibiotics. PROM, as there is risk of rupture of membranes and there is risk of infection to the mother, PROM, you have to definitely give antibiotics. Preterm labor, there is no role of antibiotics. Am I clear with this point? Right. But all patients, you have to take a high vaginal swab. For group B streptococcus. For all patients, you have to take a high vaginal swab for group B streptococcus, because group B streptococcus can cause neonatal meningitis. So if group B streptococcus is positive, then you have to give injection benzyl penicillin at the onset of labor. Injection benzyl penicillin at the onset of labor. Done? Next, if she is less than 34 weeks, you have to give tocolysis, you have to give steroids, and you have to give magnesium sulfate for neuroprotection. This also has been asked in MCQ, neuroprotection. Right? More than 34 weeks delivery. More than 34 weeks delivery. Dheeraj, no, sperms are only 55 microns. Even if you put stitch, they will escape and go inside. Stitch does not stop their entry. Anyway, they don't require to go inside because she's already pregnant. Inter-pregnancy interval may also stitch does not stop their entry. Okay, right? This is what I spoke for the Dheeraj doubt. Right, now in this recent tiny CET may, they've asked you the dose of the steroids, guys. You got a question on the dose of steroids. Can we quickly recap the dose of steroids? Betamethasone, 12 milligrams, 2 doses, 24 hours apart. IM. Dexamethasone, 6 milligrams, 4 doses, 12 hours apart. Again, this is also IM. So betamethasone, 12 milligrams, 2 doses, 24 hours apart IM. Dexamethasone, 6 milligrams, 4 doses, 12 hours apart IM. Okay. This protects from RDS, NES, RDS, respiratory distress syndrome, NEC, necrotizing enterocolitis, and IVH, intraventricular hemorrhage. What is a tocolytic of choice? Rubik, what is a tocolytic of choice? Nifedipine. Tocolytic of choice is nifedipine. The tocolytic for cardiac patients is atosiban. Atosiban is an oxytocin antagonist. Tocolytic with maximum side effects to the mother if the beta adrenergics like salbutamol, terbutaline, isoxaprine, ritodrin. So they cause tremors, tachycardia. So they cause tremors, tachycardia, and they cause hypotension, hyperglycemia, hypokalemia. Very rarely they will cause pulmonary edema. Apart from this, we have magnesium sulfate. We also have Saldinac, indomethacin, which causes premature closure of patent ductus arteriosus. Now, for PROM patients, the only thing which is extra is PROM patients, you have to give antibiotics to prevent chorioamnionitis. That's the only difference. Commonly used antibiotic is tab, erythromycin, 250 milligrams QID. Tab, erythromycin, 250 milligrams QID for 10 days. Okay. Right. Coming to the pregnancy trimesters. How many trimesters do we have now, guys? How many trimesters do we have? So we have 4 trimesters now. First trimester is up to 14 weeks. Second trimester is up to 28 weeks. Third trimester is up to 42 weeks. Fourth trimester is post-delivery up to 12 weeks. So first trimester is up to 14 weeks. Second trimester is up to 28 weeks. Third trimester is up to 42 weeks. Fourth trimester is post-delivery up to 12 weeks. Right? Now, folic acid we have to give pre-pregnancy. Start 3 months prior or at least start 3 months prior or at least 1 month prior. Right? So in first trimester, prophylactic dose and therapeutic dose. Prophylactic dose, you will continue only the first 3 months. Therapeutic dose, you will continue throughout the pregnancy. Prophylactic dose, you will give only the first 3 months. Therapeutic dose, you will continue throughout the pregnancy. Right? So prophylactic dose is 400 micrograms as per WHO, 500 and 500 micrograms as per India. 400 micrograms as per WHO and 500 micrograms as per India. Therapeutic dose is as per WHO 4 milligrams and as per India is 5 milligrams. The indications of giving therapeutic dose are previous neural tube defects, family history of neural tube defects, sickle cell anemia, and patient on anti-epileptics. Prophylactic dose you give up to 14 weeks. Therapeutic dose you give throughout the pregnancy. Now, can you tell me how much iron you give in pregnancy? So iron, calcium and all you start in second trimester. Iron, how much we give? Iron, we give 60 milligrams of elemental iron. 60 milligrams of elemental iron plus 500 micrograms of folic acid for 180 days in pregnancy and postpartum. 180 days postpartum. Calcium, 1000 milligrams per day. Never give iron and calcium together. Never give iron and calcium together. Correct? Yes, excellent. Now vaccination. What is a vaccination we give? 2 doses of Tdap. 6 weeks apart. 2 doses of Tdap 6 weeks apart. Yeah. The government supply which is free is TD. 2 doses of TD 4 to 6 weeks apart. If previous delivery within 5 years, then only single booster dose. If previous delivery within 5 years, then only single booster dose. Okay? Right. Now, next thing is that what are the minimum A and C? Yeah, 4 to 6 weeks apart. Not everything is same. So 4 to 6 weeks apart. 4 to 6 weeks apart. Previous delivery within 3 years, then single booster dose. What are the minimum A and C visits as per WHO? Okay. What are the minimum ANC visits as per WHO? Yeah, I've changed it. I changed it. So minimum ANC visits as per WHO is 8. What are the minimum ANC visits? No. As per WHO, the minimum number of ANC visits have now been changed to 8. Whereas minimum ANC visits, India is 4. Just now, ICMR guidelines, as per ICMR guidelines, not even as per Williams, ICMR guidelines 2024 के हिसाब से the calorie requirement for first trimester is 0 kilocalories. For second and third trimester is 350 kilocalories. Lactation 6 months. $600 kilocalories. I think this is visible, no? So that these are all the basic things which you should be knowing. So we have revised the basic. Now we have revised the basic. Now we'll go to the next one. Right. Aneuploidy screening may. First trimester, what you have is combined screening method. First trimester, 11 to 14 weeks, what you have is combined screening method. So how do I remember the 11 to 14 weeks ka screening method of choice is beta, papa, auntie. When it was initially beta, papa, itna khas nahi hai. So itna nahi chala. So what is the screening method of choice between the 11 to 14 weeks, guys? Beta, papa, auntie. I hope this comes, hai na? So first trimester mein the screening method of choice is beta HCG, PAP A, and NT scan. So what is NT scan? This is the NT scan. NT scan mein neck should be in neutral position. It should be neither extended nor flexed. Nape of the neck mein you should have a translucent area. Nasal bone mein you should see 2 parallel white lines. NT scan is done when crown rump length is between 45 to 84 mm. How much? 45 to 84 mm. And when you perform it between 11 to 14 weeks of gestation, CRL less than 3 mm is considered to be normal. more than or equal to 3 mm. Most common aneuploidy is Downs, followed by Turner's. Most common congenital malformation is cardiovascular. Most common congenital malformation is cardiovascular. What is the screening method of choice in second trimester? Screening method of choice in second trimester is quadruple marker. So you should know what all are included in the quadruple marker. It is done between 15 to 20 weeks of gestation. What do we have in this? Beta HCG, alpha fetoprotein, unconjugated estriol, and inhibin A. Inhibin A. So beta HCG, unconjugated estriol, alpha fetoprotein, and inhibin A. So H for high, inhibin A, I for increase. So both inhibin A and HCG will increase, whereas unconjugated estriol and alpha fetoprotein will decrease in the Downs. So what is the screening method? With, see, it is not confirmatory. What is the screening method with 99% detection rate? What is the screening method with 99% detection rate? So the screening method with 99% detection rate is non-invasive prenatal testing. Non-invasive prenatal testing, NIPT. Or it's also called as cell-free fetal DNA. Cell-free fetal DNA. So some of the fetal DNA will enter the mother circulation, and those DNAs you are picking up, and that will give you 99% detection rate. Cell-free fetal DNA. Thank you so much, Aftab. Right. So can you tell me what is this? That really brings a very big smile on my face. Thank you so much for sharing that with me. So all the best for your NEET also now. So what is this? What do you think is this procedure? So if you're seeing here, under the ultrasound guidance, the amniotic fluid is being picked up. So what do you call this as? Amniocentesis. Amniocentesis. So this is amniocentesis. See, they might ask you, when do we do amniocentesis and all? So amniocentesis is done between 15 to 20 weeks. 15 to 20 weeks. Right, right. Now, what is this? So here, if you're taking, the needle is going into the umbilical cord. So this is called as cordocentesis. Cordocentesis. See the needle, where it needle is going. Now, please tell what might be this one, the third picture. What is the third picture? Yes, this is chorionic villus sampling. This is chorionic villus sampling. Can you see the needle is going in towards the placenta? So this is the chorionic villus sampling. Okay. So you have chorionic villus sampling, you have amniocentesis, and you have cordocentesis. Right? Now, before I go further, recently you got a question that patient is suspected to have neural tube defect. What should be our next step? Chorionic villus sampling, anomaly scan. Which one? Neural tube defect, what should be your next step? Anomaly scan or chorionic villus sampling? See, neural tube defect is a structural abnormality. So whenever it is a structural abnormality, you should first go for confirming that structural abnormality. How do you confirm that structural abnormality? You will confirm it by anomaly scan. Then you can go for confirmation. Then you can try to understand why they got neural tube defect. Are there any aneuploidies or anything? So what I'm trying to say is these confirmatory methods can mainly tell you about the aneuploidies, not structural abnormalities. That was recently asked in the INECET. So chorionic villus sampling, if you make a table of all these three, chorionic villus sampling, amniocentesis, and chordosynthesis. So chorionic villus sampling, the karyotype should be done between 11 to 13 weeks. Amniocentesis, it's done between 15 to 20 weeks. Chordosynthesis, it is done between 18 to 20 weeks. In chorionic villus sampling, you mainly pick up the trophoblast for karyotyping. In amniocentesis, you pick up the amniocytes or the fetal skin epithelial cells. For chordosynthesis, you mainly pick the fetal WBC. So chorionic villus sampling, you pick up the trophoblast. Amniocentesis, you pick up the amniocytes. For chordosynthesis, you mainly pick up the fetal WBCs. So chorionic villus sampling, you do it between 11 to 13 weeks. Amniocentesis, 15 to 20 weeks. Chordosynthesis, it is 18 to 20 weeks. Chordosynthesis, it is 18 to 20 weeks. Okay? Right. I do agree. Next, abortion is the most common complication for these three. For chorionic villus sampling, the abortion rate is, so I'm going to write it here itself. For amniocentesis, the abortion rate is 0.5%. For chordosynthesis, the abortion rate is 2 to 3%. For chorionic villus sampling, it is 1 to 2%. For chorionic villus sampling, it is 1 to 2%. So highest risk of abortion is there with the chordosynthesis itself. Now, please answer this question. What is the optimum method of optimum method of screening for chromosomal abnormality in a pregnancy at 13 weeks of gestation? Can you answer this? What is the optimum method of? So as they're asking you screening method, that too at 13 weeks, the what will be the answer? Combined screening method. Only when combined screening method will be problematic, that time we'll go for NIPT. Only when combined screening method will be problematic, that time we'll go for NIPT. Okay? So next, coming to the miscarriage. Miscarriage is expulsion of the products of conception outside to the outside world. So many times this question again, students ask me that at how many weeks you call it as miscarriage. For India, the miscarriage is beyond 24 weeks. So any abortion beyond 24 weeks is called as, any abortion before 24 weeks is called as miscarriage for India. For Americans, it is 20 weeks. For India, it is 24 weeks as per Indian Academy of Pediatrics. As per Indian Academy of Pediatrics, yes, I have confirmed it with the pediatrician also. So as per India, it is 24 weeks. Okay. What is the most common cause of first trimester abortion? So it is genetic. Most common cause of first trimester abortion is genetic. What is the most common aneuploidy which causes abortion? Autosomal trisomy. Autosomal trisomy. Followed by Turner's. Followed by Turner's. Whereas Turner's is more specific. Turner's is more specific. So most common cause of first trimester abortion is genetic. Most common aneuploidy is autosomal trisomy, followed by Turner's. What is the most common risk factor for first trimester abortions? What is the most common risk factor for first trimester abortion? Maternal age. Maternal age more than 35 years. Maternal age more than 35 years. Most common cause of second trimester abortion are anatomical abnormalities. Most common cause of recurrent abortion is idiopathic. Other causes for recurrent abortion are, it can be anatomical abnormalities, genetic, APLA, autoimmune, endocrine, right? So APLA can also lead to recurrent abortions. So APLA may we have a criteria called Sapporo's criteria. So what is the Sapporo's criteria? I will tell you, try to memorize now itself. One clinical and one biochemical. One clinical, one biochemical. अब भी याद रखोगे. You can remember along with me itself. So one clinical में more than 10 weeks, 3 abortions. More than 10 weeks, 3 abortions. More than 10 weeks, 3 consecutive abortions. Less than 10 weeks, 1 abortion. Less than 10, sorry, more than 10 weeks, 1 abortion of morphologically normal fetus. Death of a normal fetus of more than 10 weeks. More than 10 weeks, 1 abortion of a morphologically normal fetus. Less than 10 weeks, 3 consecutive abortions. Less than 10 weeks, 3 consecutive abortions. And 1 premature delivery before 34 weeks in view of severe preeclampsia. And there can be history of thrombosis. Antibodies are anti-cardiolipin antibody, anti-beta-2 glycoprotein 1 antibody, and lupus anticoagulant. Antibodies are anti-cardiolipin 1 antibody, anti-beta-2 glycoprotein 1 antibody, and lupus anticoagulant. So it can be medium to high titers 2 times, 12 weeks apart. So when you have 1 clinical and 1 biochemical, you call it as APLA positive. Can you tell me what is the treatment for APLA? What is the drug of choice for APLA? Beyond 24 weeks, fetus is considered to be viable. So the treatment of APLA is low molecular weight heparin plus aspirin. Low molecular weight heparin plus aspirin. Okay, now tell me one more thing. Can torch infections cause recurrent abortion? Can torch infections cause recurrent abortion? Yes, aspirin plus low molecular weight heparin. Aspirin plus low molecular weight heparin. Torch will never cause recurrent abortions. Torch will never cause recurrent abortion. Okay? Why? We are having, once we get any of the toxoplasmosis or rubella, we tend to develop the antibodies against it. So there's only one infection which can cause recurrent pregnancy loss, that is syphilis. So congenital syphilis causes, what is this law called as? Kassavitz's law. So what is in this Kassavitz's law? With every pregnancy loss, gestational age increases. So if we have, pregnancy loss now at 16 weeks, next pregnancy loss will be at 20 weeks. Then further pregnancy loss will be at 28 weeks. Then one day you'll have a normal live baby. Then you'll have an abnormal baby. So with every pregnancy loss, if gestational age increases, that we call it as Kassavitz's law. It is seen with congenital syphilis. Right now, coming to the types of abortions, also we'll quickly recap. So abortion means new MTP law and the medical methods of termination are important. That also we'll discuss. So types of abortion में the classical triad of abortion is amenorrhea, pain, bleeding. But it is mainly follows amenorrhea, bleeding and pain. So it should follow amenorrhea, bleeding, and pain. So in threatened abortion, ABP will be there. Uterus equal to period of gestation. Os closed. Treatment reassure. Inevitable. The process of abortion has gone to that stage where it cannot reverse back to normal. So again, you'll have amenorrhea, bleeding, and pain. Uterus will be equal to period of gestation, but os will be open. Treatment, you have to go for MTP. Incomplete may all the products have gone out. So again, they'll have amenorrhea, bleeding, and pain. Uterus will be less than, some products have gone out, some products are still inside. So uterus will be less than period of gestation. Os will be open. Treatment will be MTP. See, there are only two abortions where os is open. Both which are starting with I. Both which are starting with I. So both in inevitable and incomplete, os will be open. Complete abortion may pain and bleeding will subside. Uterus will be less than period of gestation. Os is closed. Treatment is plus or minus antibiotics. Missed abortion is called as incarcerated abortion or carneous mole. So here you'll have brownish discharge. Uterus will be less than period of gestation. Os should be closed. Treatment should be again MTP. Treatment should be again MTP. So missed miscarriage may, you will see sonographically, crown rump length will be less than 7 mm and no heartbeat. Ultrasonography, how do we define the missed miscarriages? When crown rump length is less than 7 mm with no heartbeat, or when mean sac diameter is less than 25 mm with no embryo. There are two more definitions, but I feel these two are the most important. Okay? MTP. Guys, can you tell me what are all the new MTP laws? Whichever you know, you keep on telling me. What are the new MTP laws which you know? Now, for rape, incest, for humanitarian ground, that is rape, incest, and for genetic, yes, termination up to 24 weeks. Termination up to 24 weeks. And for contraception failure, it's only up to 20 weeks. For rape, genetic, and incest, termination is up to 24 weeks. But for contraception failure, it is up to 20 weeks. For contraception failure, it is up to 20 weeks. This is a very important point. Very good. Excellent. Now, for lethal anomalies, matlab where the life is not at all possible. Lethal anomalies, no upper limit. No upper limit. But who will decide that whether it is a lethal anomaly or not? So it is decided whether it's a lethal anomaly or not by a group of doctors where you have a radiologist, a pediatrician, a gynecologist, and members notified by the state government. So for rape, incest, Genetics abnormalities, termination is up to 24 weeks. For contraception failure, it is up to 20 weeks. For legal abnormalities, there is no upper limit of termination. Okay, right. So for rape, incest, genetic termination, and up to, right. Next, up to 20 weeks. One doctor opinion, 20 to 24 weeks, two doctor opinions. So up to 20 weeks, one doctor opinion, 20 to 24 weeks, two doctor opinion, right? So these are certain rules what we have, and privacy of the woman will be maintained. And bill has replaced married woman to woman and her partner. So even unmarried woman can get a MTP done now, right? Now, less than 18 years and mentally retarded, guardian consent. More than 18 years, women consent. More than 18 years, women consent. No need of the partner consent, right? What are the, and less than 18 years. This was asked in the INECT as a question, guys. Less than 18 years, inform police. First, you have to inform the police. Less than 18 years, first you have to inform the police. Okay? Right. Next is, what are the indications? Indications, genetic, when you have uh, humanitarian ground, genetic, humanitarian ground. What else can you keep telling? Life threatening for the mother, to save the life of the mother, contraception failure, and if continuing of the pregnancy can cause grievous injury to the life of the mother, grievous injury or mental injury to the mother. These are certain indications. Is large family size an indication for MTP? No, no. What are the methods of termination we have? So we have medical methods and surgical methods. Medical methods may, very good, that no is correct. So in medical methods, first trimester and second trimester. So in medical method, first trimester and second trimester. So first trimester may we have mainly Miffy and Myso. So day 1, mifepristone 200 milligrams per oral. Day 3, misoprostol 800 micrograms per vaginal. First trimester is more effective when you give up to 9 weeks. Before doing any MTP, mandatory USG. Mandatory USG. Before you perform any MTP, you should mandatorily do USG. Correct? Very good. Excellent. A, correct. Next, coming to the second trimester. Second trimester may again day 1, it is Miffy. You have this also 200 milligram per oral. Day 2, Myso 400 micrograms PV. Or Myso 400 micrograms every 3 hours. Total 5 doses. Yeah, this I'm raising it up. You can either give MIFI and MISO regimen in the second trimester also, or you can give MISO 400 micrograms every 3 hours, total 5 doses. Medical management in the first trimester, you can give only MISO also. You can also give methotrexate combinations. Second trimester, you can give oxytocin, dinoproston. What is dinoproston, guys? And you also have intraamniotic instillation of hypertonic urea and normal saline, and extraamniotic instillation of ethacridine lactate and prostaglandins. Yes, dinoproston is PGE1. Dinoproston is PGE1. Okay, so that is about the medical methods. Coming to the surgical methods. So surgical method mein you should be in a position to identify this picture, guys. So this first picture is menstrual regulation syringe, which is outdated. We don't use the syringe anymore. This is called manual vacuum aspiration syringe. What is the difference between menstrual regulation syringe and manual vacuum aspiration syringe? Menstrual regulation syringe will have only one piston. Manual vacuum aspiration syringe will have two pistons like this. Manual vacuum aspiration syringe will have two pistons like this. Okay. Menstrual regulation syringe is a 50 ml syringe. Manual vacuum aspiration syringe is a 60 ml syringe. This is the suction and evacuation pump. This is the suction and evacuation pump. Okay. So this is a 50 ml syringe. This is a 60 ml syringe. With double valve. Yes. This is the suction and evacuation. This is first trimester, only used up to 6 weeks. Done under mild sedation. We don't do menstrual regulation nowadays. It is outdated. So let's just push it out. Let us discuss about manual vacuum aspiration and suction and evacuation. Both these are done up to 13 weeks. Manual vacuum aspiration, 60 ml syringe with double valve, which creates a negative pressure of 660 mmHg. Yes, easy to remember. 60 ml, 660 mmHg. Everything is 60, 60. 60 ml, 660 mmHg. Suction and evacuation is this creates a negative pressure of 600 mmHg. This creates a negative pressure of 600 mmHg. Both of these used up to 13 weeks. Both of these are used up to 13 weeks. How do you calculate the size of the Karman's cannula which you should insert? So this is done under sedation or mild local anesthesia. This is done under general anesthesia. This requires OT. Suction and evacuation requires OT, which requires electricity, guys, between manual vacuum aspiration and suction and evacuation, which requires electricity. Yes. Suction and evacuation requires electricity. It is so obvious, no? In the name itself, it is there. Manual vacuum aspiration. So that means it is from hand only. है ना? Excellent, Bunny. Correct. Manual vacuum aspiration is mainly designed to use in the PHCs because it doesn't require anesthetist and all. So it is aram se done. Okay. Now, how do you decide the size of the Carmen's cannula? So the size of the Carmen's cannula is equal to gestational age in weeks in even number. Yes, in even number. So if she's 10 weeks, you will use 10 cannula. If she's 9 weeks, also you will use 8 cannula. If odd number gestational age, then you'll use one size less cannula. One size less cannula. If odd number gestational age, then you'll use one size less cannula. This also is important. Surgical methods for the second trimester, and even in the first trimester also you can use. So this is also one more. This is called, do you know what is the name of this picture? What forceps is this? Can you answer, guys? Yes, this is ovum forceps. This is ovum forceps. It does not have a catch and it will be like this cup. Okay, this is a ovum forceps. What is this, guys? This is a uterine curette. This is a uterine curette. So in the uterine curette, one end will be sharp and one end will be blunt. So if you observe here, this is the sharp end. If you observe this here, this is the blunt end. So for gynecological procedures, you are going to use the sharp end. For gynecological procedures, you are going to use the sharp end. But obs like this, for abortion and all, you'll use the blunt end. Now answer this question. A 32-year-old woman presents with, for her 12-week scan, she has been pregnant once before but had first trimester miscarriage. She reports no problem with this pregnancy and has no vaginal bleeding or spotting. The scan shows no fetal cardiac activity. What is the likely diagnosis? Scan is showing no fetal heart activity. So what should be the diagnosis? Yes, excellent, Dilip. Concept of medicine. So this is nothing but the very good, Sunny. So this is nothing but the missed miscarriage. Right, coming to the ectopic pregnancy. What is the most common site of ectopic? Fallopian tube. Most common site is ampulla. Earliest to rupture is isthmus. Last to rupture is interstitial. Any ectopic which is present in ampulla and fimbrial will undergo tubal abortion. Tubal abortion, right? Very good. What is the most common cause of ectopic, guys? What is the most common cause of ectopic? So most common cause is previous PID. Any infection to the tube can damage the cilia, no? So when there is a damage to cilia, they will have ectopic, right? So most common cause of ectopic is PID. Second most common cause of ectopic is previous ectopic. Highest risk is with previous tubal surgeries. Highest risk is with previous tubal surgery. Any surgery on the tube can act as a risk factor for ectopic pregnancy. Any surgery on the tube can act as a risk factor for ectopic pregnancy. Now, first, ruptured ectopic. See, ruptured ectopic is like a bomb blast in the abdomen. Classical triad is again same. Amenorrhea. Here, pain abdomen will be the predominant symptom. So, pain abdomen and mild bleeding for vagina. So, ruptured ectopic mein, you'll again have amenorrhea, pain abdomen, and bleeding for vagina. Pain abdomen is the predominant symptom. On examination, patient is in shock. For abdomen, you'll have all the signs of hemoperitoneum. PV, very, very classical point of the PV is cervical motion tenderness will be positive. Yes. Any question gives you cervical motion tenderness positive, I think you can go for the ruptured ectopic. Don't go for a gynecological case with ruptured ectopic. Gynecology mein, where will be the cervical motion tenderness positive? In PID, pelvic inflammatory disease also, cervical motion tenderness will be positive, right? So ruptured ectopic mein bomb blast inside the abdomen. So amenorrhea, pain abdomen, bleeding for vagina. On examination, patient is in shock, syncopal attack, all that. Okay. Per abdomen, you'll have signs of hemoperitoneum. PV, cervical motion tenderness will be positive. What is the management? It is immediate laparotomy. Followed by salpingectomy. So management will be immediate laparotomy followed by salpingectomy. So coming to the unruptured ectopic. So unruptured ectopic is like a silent bomb sitting inside. So most used investigation of choice is TVS, and where you have something called as bagel sign, that is gestational sac in the fallopian tube. And on Doppler, you'll have ring of fire appearance. On Doppler, you'll have ring of fire appearance. What is a gold standard for diagnosing unruptured ectopic? What is a gold standard for diagnosing unruptured ectopic? So gold standard is laparoscopy. Management of the unruptured ectopic is very important, guys. Management is very important. See, this is the ring of fire appearance. Ring of fire appearance. So bagel sign is nothing but on USG, when gestational sac will be in the fallopian tube, no? This will look like a donut in the fallopian tube. So that donut in the fallopian tube, we call it as bagel sign. Donut in fallopian tube. So that donut in the fallopian tube is called as bagel sign. Okay. So this is a ring of fire appearance, Akka Gola. Because of the increased vascularity around the gestational sac, you'll see ring of fire appearance. Now, management is the most important, guys. I want you to know the management extraordinarily imprinted in your brain. 3 modalities of management: expectant, medical, surgical. So we have three modalities of management: expectant, medical, and surgical, right? So expectant, you're not doing anything, just waiting it for it to resolve by itself. Medical may you're giving methotrexate. Surgical may you're going to remove the fallopian tube. Okay. The points for expectant and medical are almost similar. Only for the surgical, it will change. Okay. So for expectant, gestational sac should be less than 3.5 centimeters. Here more than 3.5. Mild or no pain. Surgical may there will be significant pain. So expectant may gestational sac will be less than 3.5 and mild or no pain. Surgical may there will be significant pain. FHR absent. You are positive. Ready, not ready for follow-up. Same point goes here. Here, not ready for follow-up. Okay. So expectant management may gestational sac will be less than 3.5. Medical management may also it will be less than 3.5. Surgical may it will be more than 3.5. Mild or no pain, FHR absent, and ready for follow-up. Beta HCG is the only one which differs among these three. Beta HCG less than 1000, you can do just expectant management. Beta HCG less than 5000, you'll do medical management. More than 5000, you'll do surgical management. Beta HCG is the one which will decide the management for all these three. So beta HCG less than 1000, less than 1000, less than 5000, and more than 5000. So you have three different beta HCG levels. Okay. So expectant may you're not doing anything, but medical management may the drug of choice is injection methotrexate. 50 milligram per meter square. 50 milligram per meter square. It is made on based on body surface area. Then you measure the beta HCG on day 1, day 4, day 7. How much should be the drop in beta HCG, guys? And please remember, this is IM injection. Single dose is good enough as multiple dose. So we usually give single dose regimen itself. So drop should be more than 15%, then patient is responding. Drop less than 15%. Repeat injection. Drop less than 15%, you have to repeat the injection. Surgical management may you can do self-injectomy. Best is self-injectomy. There won't be chance of recurrence. That is complete removal of the tube. Otomy and ostomy should be done when already she has lost one tube and she has only one tube left with her. Then you will go for otomy or ostomy. Salpingotomy. Salpingostomy. But ectomy is the best. Ectomy is the best. Am I clear, guys? So can you tell me when do we do? Yes, maximum only 3 doses. Now, can you tell me when do we go? When do we do? What should be the beta HCG level to do medical management? What should be the beta HCG level to do medical management? What should be the beta HCG level to do surgical management? What should be the beta HCG level to do expectant management? So abdominal pregnancy, the criteria for abdominal pregnancy is Studi-Fort's criteria. Studi-Fort's criteria. So abdominal pregnancy, the criteria for the abdominal pregnancy is Studi-Fort's criteria. Ovarian pregnancy, it is called Spiegelberg's criteria. Spiegelberg's criteria. Very good. Less than 1,000, more than 5,000, less than 1,000, more than 5,000, and less than 5,000. Cervical pregnancy, Rubin's or Palmer's criteria. How am I going to remember? Abs. Who will have abs? Stud-like person will have abs. So abdominal pregnancy, Studi-Fort's. Ovarian, Spiegelberg. Cervical, Rubin's. Next, you have a concept called pregnancy of unknown location. UPT is positive, but no sac on USG. So when UPT is positive, but there is no sac on USG, you call it as pregnancy of unknown location. Then you have to do serum beta HCG. If serum beta HCG is less than 1500 international units per liter, then obviously you will not see the gestational sac. Then what you should do? You should do serial beta HCG monitoring. Every 48 hours. Then you have to do serial beta HCG monitoring every 48 hours. When you're doing serial beta HCG monitoring, if there is rise in beta HCG by 63%, then it is an intrauterine pregnancy. If rise in beta HCG is more than 50%, but less than 63%, then it is an ectopic. If rise in beta HCG is less than 50%, it's a biochemical pregnancy. So you have to do serial beta HCG monitoring every 48 hours. So if there is a rise in beta HCG by 63%, it's an intrauterine pregnancy. If the rise in beta HCG is more than 50%, but less than 63%, it's an ectopic. If there is a rise in beta HCG, which is less than 50%, it's called a biochemical pregnancy. Am I clear? Chalo, let's go to the next topic. Okay, can you answer this question? A 28-year-old presents with first pregnancy at 16 weeks of gestation with severe hyperemesis. Her blood pressure is 150/96, 3 plus proteinuria. Her blood pressure is noted to be 110/70, booking blood pressure. Abdominal examination is 22. Matlab she is 16 weeks, but it is 22. What is your diagnosis? Biochemical pregnancy means it is only positive by HCG, but actually bacha is not formed. So it's only positive only by biochemical status of HCG, no? But baby didn't form. So that's why you're going to call it as biochemical pregnancy. Okay? What is the answer for this question, guys? Excellent. This is hydrated for mole. Wonderful. You all have answered correct. See, uterus is more than period of gestation. There is the triad of this, there is early onset pre-eclampsia, which is one of the classical complications associated with molar pregnancy, right? So this is nothing but the hydrated form mole. See, this is how the hydrated form looks like. It's a grape-like vesicles. The only difference between partial mole and complete mole is complete mole mein you don't have fetus, partial mole mein you'll have fetus. So molar pregnancy mein you have complete mole and you have partial mole. Complete mole is amenorrhea, bleeding, pain. Partial mole is also amenorrhea, bleeding and pain, but partial mole may you'll have passage of uterus will be equal to period of gestation. Partial mole may, sorry, complete mole may uterus can be more than period of gestation. Partial mole may uterus will be equal to period of gestation. Yeah, less than. Right? Complete mole is diploid 46XX or 46XY. Partial mole is triploid 69XXY or 69XXX. This is most common. This is most common. Very, very, very classical appearance in both of them is snowstorm appearance on USG. Snowstorm appearance on USG. So we see snowstorm appearance on USG. Treatment is suction and evacuation. Suction and evacuation. Simple. Complete mole में if gestational age is more than, sorry, if she is 40 years and more and family is complete, complete mole में it is 40, if she is 40 years above and family is complete, then you can do hysterectomy because it reduces the chance of pulmonary embolism. It decreases pulmonary embolism, not choriocarcinoma. I repeat once again. Yes, I repeat once again. Complete mole and partial mole with both present you with amenorrhea, bleeding and pain. Complete mole mein uterus will be more than period of gestation. Like in our question, she's only 16 weeks, but uterus will be 20 weeks. Partial mole mein uterus will be less than period of gestation. Complete mole will be 46XX or yeah 46XY. Partial mole will be triploid 69XXY, yeah 69XXX, anything. So what is a classical appearance? Snowstorm appearance. Treatment, suction and evacuation. Age more than 40 years, family complete, there you can go for hysterectomy. Okay? See, this is the snowstorm. This is the snowstorm, guys. This is the snowstorm. Follow-up is very important in these patients. Follow-up is very important in these patients. So how do you follow up? Follow up with beta HCG every week till nil and 3 consecutive weeks. And then monthly for 6 months. So follow-up is with beta HCG every week till nil and 3 consecutive weeks and then monthly for 6 months. Yes, up to 6 months, you should not ask her to get pregnant. So contraception of choice for this 6 months is combined oral contraceptive pills. Combined oral contraceptive pills. Contraceptive which is contraindicated is IUCD. Contraceptive which is contraindicated is IUCD. Never put IUCD because IUCD will perforate the uterus. IUCD will perforate the uterus. Okay? Right? Now coming to the hypertension, guys. So first definitions of hypertension. Can we just speak about the definition, different definitions? So I think you all know the different definitions, no? Orally, I'll tell definitions and then we'll see the question. I will tell you the case scenario. You should tell what hypertension is it. Hypertension which has been seen before pregnancy or before 20 weeks. What is that? Hypertension which is seen before pregnancy or before 20 weeks. What is that? So hypertension which is present before pregnancy or before 20 weeks is chronic hypertension. Chronic hypertension, correct? So what is the hypertension which is present? You want me to tell, Bunny, you want me to tell all those conditions where period of gestation and height of the uterus? Okay, so what are the conditions where, one second before we go to the hypertension, I'll just tell the query of the Bunny. So what are the conditions where height of the uterus will be more than period of gestation? Wrong dates. First and foremost, wrong dates. Wherever uterus can be big, either due to big baby or due to more fluid. Polyhydramnios. You can also keep on telling guys, GDM, because macrosomia will be there. Macrosomia. And we have twin pregnancy. Okay. Right. Next, hydrops. Fibroid. Full bladder. Molar pregnancy. These are certain conditions where you'll have uterus more than period of gestation. Okay. So usually less than or more than period of gestation, you should always think in terms of, wrong dates. Check the dates first. Check the menstrual history first. Okay, let's go back to this. So first I asked you, whenever they have blood pressure before pregnancy or before 20 weeks, it's a chronic hypertension. Excellent. When they have blood pressure after 20 weeks of gestation and blood pressure has persisted beyond 12 weeks, then what do you call it as? Blood pressure has developed after 20 weeks of gestation and blood pressure has persisted beyond 12 weeks of pregnancy. What do you call this as? It is not gestational hypertension. It is not gestational hypertension. What did I tell? She has blood pressure. See, that is why you should read the question very well. Blood pressure after 20 weeks. And what did I tell? Blood pressure persisting beyond 20 weeks. Beyond 12 weeks delivery. What do you call this as? Come on, come on, come on. You are all answering in forms. Okay. See, when you have blood pressure coming for the first time after 20 weeks, if you want to call it as gestational hypertension, blood pressure should come back to normal within 12 weeks of delivery. When blood pressure persists beyond 12 weeks, although blood pressure has come after 20 weeks, but if it is persisting beyond 12 weeks, this will be again called as chronic hypertension, guys. This will be again called as chronic hypertension. Understood? So what is gestational hypertension? Gestational hypertension is blood pressure beyond 20 weeks and blood pressure will come back to normal within 12 weeks of delivery. And gestational hypertension, there won't be associated proteinuria. Gestational hypertension, you won't have associated proteinuria. Pre-eclampsia is hypertension for the first time after 20 weeks, and it is associated with proteinuria. And it is associated with proteinuria. Okay. In the absence of proteinuria, in preeclampsia, you will have end organ damage signs. What are the end organ damage signs? Like headache, liver failure, kidney failure, lung failure, all that. Blurring of vision, headache, right? Next, if you have end organ damage with preeclampsia, it is always, always, always called as severe preeclampsia. It is always called as severe preeclampsia. Convulsions, convulsions with hypertension is eclampsia. You have a chronic hypertensive patient with end organ damage. Chronic hypertensive patient with end organ damage. That is called chronic hypertension with superimposed preeclampsia. Okay. Now, please read this question and tell me what is your diagnosis for this patient. So please answer this question. I'll be back in a minute, guys. Right. So did you answer this question? So coming back. So you all have answered, some of you have answered D, some of you have answered C. Let me see the answer now. 32-year-old, blood pressure of 150/100 at 32 weeks. There is headache and blurring of vision. Her blood pressure before pregnancy is 150/90. So as her blood pressure before pregnancy is 150/90, this is called chronic hypertension with superimposed preeclampsia. So if we would have written her blood pressure before pregnancy as 150, 120, 80, then what would have been the answer? If it would have been less than 120, 80 before pregnancy, then your answer would have gone for severe preeclampsia. Okay, now let me change it. Let me change the question. Let me change the question. If I remove proteinuria of 3 plus and her blood pressure before pregnancy as 120, 80, then what will be your answer? If I remove 3 plus and I write that her blood pressure before pregnancy is 120, 80, then what will be your answer? Then your answer will go to, still your answer will remain severe preeclampsia. See, blood pressure need not be 160, 160, 110 above to call it a severe preeclampsia. If they have end organ damage signs, even if they don't have blood pressure of 160, 110, or if they don't have proteinuria, still you are going to call it a severe preeclampsia itself. If they have impending signs, if they don't have the other symptoms also, still we are going to call it as severe preeclampsia. Okay? Right. So next is, why do we see this? So we let me differentiate between mild preeclampsia, severe preeclampsia, mild and severe. So mild is less than 160, 110. Severe is more than 160, 110. Mild may there is no end organ damage signs. Severe may end organ damage are present. End organ damage is present. So this pathophysiology is very important. So I'll definitely discuss the pathophysiology. So in this pathophysiology, normally you'll have the some of the trophoblasts coming outside into the artery, spiral artery. Normally, some of the trophoblasts will enter into the spiral artery and break the elastic lamina of the spiral artery and make it high velocity, low resistance vessel. But what is happening here? Here, there is failure of trophoblastic invasion. So in exam, you got a question that which trophoblast invades which artery? So which trophoblast invades which artery, guys? Extravillous trophoblasts. Extravillous trophoblasts invade the spiral artery. Extravillous trophoblasts invade the spiral artery. So why do we see this preeclampsia? So preeclampsia is due to failure of invasion of నేను రాసి పెడతా నువ్వు ఇక్కడ పోయి వండుకో రాస్తా sorry guys, so this is failure of secondary trophoblastic invasion. So this is failure of secondary trophoblastic invasion. So because of the failure of secondary trophoblastic invasion, spiral arteries will not be invading. Spiral arteries will not be invaded by the extravillous trophoblast. Spiral arteries will not invade the extravillous trophoblast will not invade the spiral artery. So spiral artery will become high resistance, low velocity vessel. That will create uteroplacental insufficiency. I want you to tell me, if you're preparing for NEET, this is very important. So this will lead to release of all cytokines, inflammatory mediators, and everything. So that will increase the vasoconstrictors and decrease the vasodilator. So what are the vasoconstrictors which increase and what are the vasodilators which will decrease? So the vasoconstrictors which increase are SFLT1, PLGF. So the vasoconstrictors which will increase are SFLT1, PLGF. Vasodilators which will decrease are nitric oxide. Sorry. Vasoconstrictors which increase are SFLT1, endoglin. This was asked as a question, guys. Endoglin and thromboxane A2. Vasodilators which are increasing are nitric oxide, prostacyclin, nitric oxide, prostacyclin, and PLGF. Because of the increased vasoconstrictors, you're having all these complications. So increased vasoconstrictors in the brain. What will the increased vasoconstrictors in the brain will do, guys? Segmental vasospasm, cerebral vasospasm. And because of the cerebral vasospasm, we are having headaches. Cerebral vasospasm are the reason for headaches. Pulmonary vessel vasoconstriction will lead to pulmonary edema. So this will lead to headache and vomiting. And then we'll have pulmonary edema. Small vessels under the liver capsule rupture. And this will lead to epigastric pain. And this will also cause periportal necrosis in the liver. That will lead to raised LFT. It will also affect the kidney. So in the kidney, it causes glomeruloendotheliosis. And because of the glomeruloendotheliosis, there will be raised RFT and they'll have oliguria. Correct? Now you tell me. So, these all symptoms like headache, vomiting, pulmonary edema, epigastric pain, oliguria, all these are called impending signs of eclampsia. If you don't treat at the level of impending signs of eclampsia, they will go into eclampsia. If you don't treat at the level of impending signs of eclampsia, they will go into eclampsia, right? Now, my question to you is, among all these organs, which will be the first organ to be affected? Whenever there is hypertension, what is the first organ which gets affected? Is it brain or is it liver or is it lungs or is it kidney? Yes, guys, what will be your answer? Yes, excellent, Bunny. The first organ to be affected will be the kidney. So glomeruloendotheliosis is the most common presentation what we are going to see. Kidney will be the first to be affected. So in these patients, you can see raised LFT, raised RFT, all that will be seen in these patients. Okay. Very good. All of you are answering correct. Absolutely correct. Okay. Now, how do we manage these patients? So recently, they have told that you don't require to wait for the blood pressure to become 150/100. Start treating them as soon as their blood pressure is more than 140/90. So when the blood pressure is more than 140/90, you have non-specific management and definitive management. Non-specific management is drug of choice is labetalol, which is an alpha plus beta blocker. So when blood pressure is more than 140/90, the non-specific management is labetalol, which is a drug of choice. Labetalol is both alpha plus beta blocker. Maximum dose, you should not give labetalol in asthmatics. Alpha methyl is an alternative drug, but it causes autoimmune hemolytic anemia and it causes postpartum depression. Nifedipine, hydralazine, nitropuride or nitroprusside are the other drugs. What are contraindicated are ARBs, diuretics, and ACE inhibitors. Definitive management is delivery. Mild preeclampsia mein you'll deliver them by 37 weeks. Severe preeclampsia 34 weeks. Severe preeclampsia with impending signs. Immediate delivery plus magnesium sulfate prophylaxis. Yes. Okay. So when you have umbilical artery, mein normal flow is this: systole, diastole. But when you have reduced diastolic flow, that is S by D ratio more than 3, you have to do immediate delivery. If there is absent diastolic flow, like you see in this picture, you deliver them by 34 weeks. And if you have reverse diastolic flow, then you deliver by 30 to 32 weeks. So when you have a reduced diastolic flow, that is when S by D ratio is more than 3, you'll do immediate delivery. When you have absent diastolic flow, deliver by 34 weeks. When you have reverse diastolic flow, you deliver by 30 to 32 weeks. That's everything about the hypertensive disorders. A quick points about eclampsia. So eclampsia is convulsions plus hypertension. Antepartum eclampsia is the most common. First, always stabilize the patient. Stabilize. Then you check the airway, breathing, circulation. Then you give magnesium sulfate prophylaxis. Then you deliver her. Magnesium sulfate is the drug of choice. You have loading dose. You have Pritchard regimen. You have Zuspan regimen. Are you observing? We are discussing all topics, all important points. I'm not just doing a peripheral touch up of the topics. This is how we can revise. So you have to be precise when you're revising, and you can revise everything and finish everything, right? So don't give up. We have some more topics to do. Just stay with me so that we'll finish the entire other topics also. Okay? So we have Pritchard regimen and Zuspan regimen. So Pritchard regimen में we have loading dose, and maintenance dose. So loading dose is 4 grams of 20% magnesium sulfate. 4 grams of 20% magnesium sulfate plus slow IV over 20 minutes. Over 20 minutes. plus 10 grams of 50% magnesium sulfate, IM. Zuspan is only 4 grams of 20% magnesium sulfate, slow IV over 20 minutes. So Pritchard regimen is 4 grams of 20% magnesium sulfate, slow IV over 20 minutes, plus 10 grams of 50% magnesium sulfate IM. Zuspan is 4 grams of 20% magnesium sulfate, slow IV over 20 minutes. How do you prepare this 4 grams of magnesium sulfate, which is 20%? So 4 grams is made from 12 ml of normal saline plus 8 ml of magnesium sulfate. 12 ml of normal saline plus 8 ml of magnesium sulfate. Maintenance dose for Pritchard regimen is 5 grams of 50% magnesium sulfate IM on alternate buttocks every 4 hours. Whereas for Zuspan regimen, it is 1 to 2 gram per hour IV infusion. How long you will continue this regimen? So you have to continue the regimen for 24 hours after the last attack, 24 hours after last attack or delivery, whichever is later. So you have to do this 24 hours after the last attack or delivery, whichever is later. So we have Pritchard regimen and Zuspan regimen. So Pritchard regimen is 12 ml of normal saline plus both 4 grams is made same. Okay, so this both you have to remember. What are the 3 things you'll monitor whenever the patient is on magnesium sulfate? Knee jerk, respiratory rate, and urine output. What is the first to be lost? What is the first to be lost? Knee jerk is first to be lost. Knee jerk is the first to be lost. And once the knee jerk is lost, stop magnesium sulfate till knee jerk appears. Right? Urine output you monitor because magnesium sulfate is excreted unchanged in the urine. Therapeutic range is 4 to 7 milliequivalents per liter. Therapeutic range for the magnesium sulfate is 4 to 7 milliequivalents per liter. Let's solve this question. Pregnant lady with 32 weeks of gestation presents with blood pressure of 160, 110, proteinuria and retinal hemorrhages. What is the definitive management of choice in this patient? So what is your diagnosis for this patient? And then you tell me what is the definitive management for this patient. Yes, excellent, Bunny, mix up, all of you. So the definitive management for this patient is termination of pregnancy because this is severe preeclampsia with impending signs. She's having retinal hemorrhage. So that is nothing but the impending sign. So whenever you have impending sign, you have to go for directly termination of pregnancy. Absolutely correct. Absolutely correct. In this same question, you got something very similar to this in the previous INECET. In this same question, if they ask you what is the next step, then what will be your answer? If somebody asks you what is your next step, then what will be your answer? Next step will be magnesium sulfate. Whenever there is impending signs, if somebody asks you what is the next step, it will be magnesium sulfate. So first you will give magnesium sulfate, IV or IM, IV loading dose, and then you will go for the IV labetalol, then termination. Am I clear with this point, guys? First will be magnesium sulfate. After that, nifedipine or labetalol, whichever is available. Then termination. Right, now coming to the diabetes. So there are mainly two types of diabetes: overt diabetes and overt and pre-gestational diabetes, and diabetes gestational diabetes. So overt diabetes is glucose intolerance for the first time in pregnancy. Overt diabetes is the glucose intolerance. Sorry, you have overt diabetes or pre-gestational diabetes and gestational diabetes, right? So overt diabetes or pre-gestational diabetes is glucose intolerance before pregnancy. Glucose intolerance before pregnancy. Whereas gestational diabetes is glucose intolerance for the first time in pregnancy. Gestational diabetes is a glucose intolerance for the first time in pregnancy. So overt diabetes is glucose intolerance before pregnancy. So when do you call overt diabetes? When fasting blood sugar is more than 126. Postprandial blood sugar is more than 200 milligram per deciliter, or HbA1c is more than 6.5. So when fasting blood sugar is more than 1.26, postprandial is more than 200, HbA1c is more than 6.5. Drug of choice for over DM is insulin. What is the problem we have with over DM? Over DM mainly causes congenital malformations. So you have to get a fetal echo done at 18 to 20 weeks of gestation. You have to mainly get a fetal echo at 18 to 20 weeks of gestation. Okay. Now this is the most important for you to know in patients with over DM. Most specific congenital malformation with over DM is sacral agenesis or caudal regression syndrome. Sacral agenesis or caudal regression syndrome. Most common malformation is VSD more than neural tube defect. Most specific cardiac anomaly is transposition of great arteries. Am I clear with these 3 points? So what is the most common congenital malformation with overt DM? VSD more than neural tube defect. Which is the most specific cardiac anomaly? Transposition of great arteries. And which is the most specific anomaly as such with the overt DM? Sacral agenesis or caudal regression syndrome. So this is the sacral agenesis or caudal regression syndrome. Both legs fused. See, most of you think that diabetes will always cause macrosomia. Can diabetes, especially the overt diabetes, that is pre-gestational diabetes, can pre-gestational diabetes cause IUGR? Can pre-gestational diabetes cause IUGR? Yes, pre-gestational diabetes can cause IUGR if there is diabetic vasculopathy. If there is diabetic vasculopathy, then pre-gestational diabetes can cause IUGR. Okay. How do you diagnose GDM? GDM may we mainly do universal screening. At first visit and again at 24 to 28 weeks of gestation. So GDMA, you'll do universal screening at first visit and again repeat at 24 to 28 weeks of gestation. So you have 75 grams OGTT as well as you have 75 grams OGCT. So 75 grams OGTT is fasting should be, you will give it in a fasting state itself. So fasting should be less than 92 milligram per deciliter. 1 hour should be less than 180. 2 hours should be less than 153. 100 grams OGTT, 100 grams OGTT, less than 95, less than 180, 155, 140. 3 hours also we check here. If you ask me, shall I have to remember? Yes, guys, you have to remember. You have to remember. Okay. So 92, 180, 153, 95, 180, 155, 140. You also have 75 grams OGCT. What is 75 grams OGCT? That is called actually as DIPSI. Diabetes in Pregnancy Study Group India. Diabetes in Pregnancy Study Group India. So 75 grams OGCT में irrespective of the meal status, you will give 75 grams of glucose and then you will measure the blood sugars. After 2 hours. So irrespective of the meal status, you will give 75 grams of glucose and then you measure the blood sugars after 2 hours. So when you measure the blood sugars after 2 hours, if it is more than, it is less than 120 milligram per deciliter, it's called as normal. It is between 121 to 139 milligram per deciliter, it's called GDM, impaired glucose tolerance. And if it is more than 140, it's called GDM. And if it is more than 200, it's called over DM. So less than 120, it is normal. 121 to 139, it is called impaired glucose tolerance. It is more than 140 GDM and more than 200, it is called over DM. Okay. And 75 grams OGTT, if you can't remember 100 grams OGTT, at least remember 75 grams OGTT. In this, even if one value abnormal, it is called GDM. Even if one value is abnormal, then it is called GDM. Even if one value is abnormal, then it is called GDM. Right? So whenever the baby's weight is more than 4 kgs, whenever the baby's weight is more than 4 kgs, you have to go for LSCS. Whenever the baby's weight is more than 4 kgs, you have to go for LSCS. So timing of delivery for diabetes, if GDM is well controlled on diet, then you deliver them by, if GDM is well controlled on diet, then you deliver them by 40 to 40 plus 6 weeks. If GDM or over DM well controlled on medication, then you deliver them by 39 to 39 plus 6 weeks. Poorly controlled, 37 weeks. Uncontrolled, 34 weeks. Bunny Papa, she's right. So next, coming to the infant, what are the complications we see in the infant and the neonate is also important, no? So infant में baby can be motu, Peterson's hypothesis के वजह से motu, macrosomia. Because being motu, it will be stuck inside. That's called shoulder dystocia. And they can have abortions and intrauterine death. All this time, mother was continuously giving glucose to the baby. But after the baby is delivered, there won't be any more glucose to the baby. So baby will have, neonate will have hypoglycemia. And this increased, this glucose, the glucose levels will be low. But insulin is very high, so there will be hypokalemia. Insulin pushes the potassium inside the cell. There is hypocalcemia and hypomagnesemia. Because the body surface is more, there will be hypothermia. And they'll also have respiratory distress syndrome. They'll also have respiratory distress syndrome. Okay? Right? So that's about the GDM. Any doubts about the GDM, guys? Bon Nanu, Dr. Saab. Right. So I would, 2 minutes, let us speak. Like, how is your preparation going on? What are you doing for the last 4 days? Last 4 days. So, most of the time we are so much tense in this last 4 days, but you'll miss these days. You'll miss studying so much. You'll miss having something, major happening in your life. So actually cherish these moments, and just don't take too much stress. Don't read too many things. Bas bindas raho. Being bindas is very important. And one more thing, uh, go prior, take light breakfast, go prior to the examination hall. Don't stand the last minute also revising something and all. No, go inside, sit for 10 to 15 minutes where you can calm yourself, do some breathing so that you can calm yourself. Okay? Good, Bunny. Excellent. If you're calm, definitely you can do. Right, let us speak about anemia now. Now, regarding the anemia. So, when do you call mild anemia? So, mild anemia is 10 to 10.9 gram per deciliter. So, mild anemia is 10 to 10.9 gram per deciliter. Moderate anemia is 7 to 9.9 gram per deciliter, whereas severe anemia is less than 7 gram per deciliter. So mild is 10 to 10.9, moderate is 7 to 9.9, severe is less than 7. How do we manage these patients? How do we manage these patients? So, when you have mild or moderate anemia, less than 30 weeks, you will give 2 tablets of oral iron. Normally we give 1 tablet, no? Here you have to give 2 tablets of oral iron till hemoglobin improves. More than 30 weeks, it is parenteral iron. Can you name some parenteral irons? So less than 30 weeks, 2 tablets of oral iron till hemoglobin improves. More than 30 weeks, it is the parenteral iron, what you're going to give. Okay. So what is the parenteral iron which you are usually giving? So you can either give iron sucrose or you can give ferricarboxy maltose. Yes, excellent, guys. So you can either give iron sucrose or ferricarboxy maltose. Can you register this much for mild and moderate iron? Recently, you got a question. If somebody is anemic at 8 weeks, will you start iron at 8 weeks or will you start at 12 weeks? Will you start at 8 weeks or will you start at 12 weeks? Somebody has iron deficiency at 8 weeks. Start at 8 weeks only. Why are you waiting for a good muhurtam at 12 weeks? Right? You have to start immediately. Whenever they have, you have to start immediately. Okay? Right. Next is, if they have severe anemia, what will you do? They have severe anemia, what will you do? Severe anemia में, if they have less than 5 grams per deciliter at any gestational age, blood transfusion. At any gestational age, blood transfusion. Blood transfusion. At any gestational age, blood transfusion. If it is between 5 to 6.9 and if she's less than 34 weeks, parenteral iron. More than 34 weeks, blood transfusion. These two tables, if you can remember, no, you'll rock in the chapter of anemia. If these two tables you can remember, you'll rock in the chapter of anemia. Okay, can you remember this once again? Let us do this once again. Severe anemia में less than 5 at any gestational age, blood transfusion. 5 to 6.9, more than 34 weeks, it is blood transfusion. Less than 34 weeks, it is parenteral iron. Okay. Coming to the twins, you have two types of twins. Two sperms, two ovums forming two zygotes. It's called dizygotic twins. One sperm, one zygote dividing into two is called monozygotic. Monozygotic will look same to same. Dizygotic are different. So they are non-identical twins. All dizygotic twins will have their own separate placentas and own separate amniotic sac. So dizygotic are dichorionic, diamniotic. Monozygotic, how will it depend whether they are the chorionicity and amnionicity of monozygotic depends on what? So monozygotic and dizygotic, it depends on the when did it divide. So if they divide in the morula state, if they divide in the morula state, that is within 72 hours. This has been asked as a question. Recently also you got it as a question. Okay. So it will be two amniotic sac and two placentas. So it will be DCDA. If they divide in the blastocyst stage, that is between day 4 to day 8, it will have single placenta and two amniotic sacs, monochorionic diamniotic. If they divide in the implanted blastocyst stage, that is between day 8 to 13, then they'll have single placenta and single amniotic sac, monochorionic, monoamniotic. If they divide after the embryonic disc is formed, then it will result in both babies joined together. That is called conjoined twins or Siamese twins. That is beyond 13 days. Beyond 13 days. Can we repeat this once again? If the division takes place within 72 hours, it is dichorionic diamniotic. If the division takes place between day 4 to day 8, it is monochorionic diamniotic. If the division takes place between 8 to 13, it is monochorionic monoamniotic. If the division takes place between day 13 to 15, it is called Siamese twins or conjoined twins. Siamese twins or conjoined twins. Okay? What is this, guys? What is this sign called as? What is this sign called as? This is important. What is this sign called as? Yes, this is called lambda sign. This is called lambda sign, or it is also called as twin peak sign. Twin peak sign. So it is mainly seen in this lambda sign or twin peak sign is exclusively seen with dichorionic diamniotic twins. Dichorionic diamniotic twins. And it is mainly seen between 11 to 14 weeks of gestation. 11 to 14 weeks of gestation. So this dichorionic twins will show you lambda sign or twin peak sign. What is this called as? So this is called as T sign. This is called as T sign. T sign is seen with monochorionic diamniotic twins. T sign is seen with monochorionic diamniotic twins. Right? What is this which you're observing here? What is this which you're observing here? So this what you're observing here, this is called twin-to-twin transfusion syndrome. Twin-to-twin transfusion syndrome. So this is only seen in monochorionic diamniotic placenta. Monochorionic diamniotic placenta, where there is a deep arteriovenous malformation. Yes, very good. And one baby is giving blood and the other baby is receiving the blood. So the baby which is giving the blood is called donor twin. And the baby which is receiving the blood is called recipient twin. Donor twin will be anemic, whereas recipient twin will be polycythemic. So donor twin will be anemic, whereas the recipient twin will be polycythemic. Donor twin will have oligohydramnios, recipient twin will have polyhydramnios. Worst prognosis for the recipient twin. Worst prognosis for the recipient twin. This is all due to deep AV malformation. So what should be the treatment for this? Fetoscopic laser ablation. Which type of placenta do you see twin-to-twin transfusion syndrome? In which type of placenta do you see twin-to-twin transfusion syndrome? So twin-to-twin transfusion syndrome is seen only with monochorionic diamniotic placenta. Only with monochorionic diamniotic. Not with any other. Only with monochorionic diamniotic. Correct. So management for monochorionic monoamniotic, as there is risk of cord entanglement, you have to go for cesarean section at 32 to 34 weeks after giving steroids. So for monochorionic monoamniotic, you have to go for cesarean section at 32 to 34 weeks after giving steroids. Monochorionic diamniotic, you'll do elective delivery at 36 to 37 weeks. Dichorionic twins, elective delivery at 37 to 38 weeks. Triplets, 35 weeks. 35 weeks. How do you decide the mode of delivery in the twins? How do you decide the mode of delivery in the twins? How do you decide the mode of delivery in the twins? It is mainly decided by the first twin. If first twin is cephal, you will always go for vaginal delivery. Irrespective of the second twin. Correct. Presentation of the first twin will tell you what will be the mode of delivery for the second twin. If first twin is cephal, you'll always go for the vaginal delivery, irrespective of the second twin, right? So, if second twin is breech, you will do assisted vaginal breech delivery. If second twin is transverse lie, yes, then what will you do? Yes, mix up. What should you do if the second twin is transverse lie? If second twin is transverse lie, you should first try to pull the baby by its legs. That is called internal podalic version. So if second twin is transverse lie, you will do internal podalic version. Followed by breech extraction. Followed by breech extraction. Okay? Right? So if first twin is non-cephal, irrespective of the second twin, you'll go for LSCS. Monochorionic, monoamniotic, you'll go for LSCS. Yes, internal podalic version mein you hold the baby's leg and pull it out. You hold the baby's leg and pull it out. That is called internal podalic version. Okay, guys? Right. So now we'll discuss about the labor. How do you determine the position of the fetus? First and foremost, 3 steps you have to follow to determine the position of the fetus. What lie is this? So this is called as longitudinal lie. Longitudinal lie. What presentation is this? Presenting part is this. Whenever you do PV, whatever you feel first, that is called presenting part. So what will be the presenting part here? Face is the presenting part here. What is the denominator for the face? What is the denominator for the face? So the denominator for the face is mentum. Mentum. The denominator for the face is mentum. Now, whether this mentum is seeing forward or backward, we have to see. If mentum is towards the pubic symphysis, like here, we call it as mento anterior. Now you have to see always your right is patient's left because patient is lying opposite to you. So this is the right, this is the left. This is the right and this is the left of the patient. So it is towards the right side. Our right and left will be ulta to the patient's right and left. Our right and left will be ulta for the patient. My right will be patient's left. My left will be patient's right. Your right and left will be ulta for the picture. Remember that point. Okay? Right. Vertex is occiput, but this is not vertex, no? This is face. So that is why the denominator should be mentum. Shubham, did you understand? Here, this is the face as the presenting part. As face is the presenting part, the denominator should be mentum. The denominator should be mentum. So this is mentum and this is on the right side. So this is actually right mento anterior. I want you to answer for this second picture, guys. No, यहाँ पे भी अगर आप देख रहे हो, आप पीवी कर रहे हो तो क्या दिख रहा है? बच्चे का फेस दिख रहा है ना? आप पीवी कर रहे हो तो अगर बच्चे का फेस है तो उसे हम क्या कहते हैं? उसे हम कहते हैं फेस एज द प्रेजेंटिंग पार्ट एंड व्हाट विल बी द डिनोमिनेटर हियर? द डिनोमिनेटर विल बी mentum. So what will be the answer for this picture now? This is the mentum. ठीक है? अभी ये mentum आगे की तरफ है कि पीछे की तरफ है? Yes. So first and foremost, this is the left, this is the right. Your right and left will be ulta to the picture. For you also, it will be the same itself. There won't be any difference. So this is right mento posterior. I think better to discuss tomorrow, no? So this is right mentoposterior. Seat is on the right side. It is mentum and it is towards the sacral promontory. So this is right mentoposterior. Yes. So I have further discussion about labor. So tomorrow you'll have the second half of this video where I'll be discussing about the labor and I'll be discussing about the gynec. So I hope you all enjoyed today's session. You want me to finish it off, finish the entire ops today itself? Okay, no problem. That's fine. So next, coming to the Leopold maneuvers. What is this Leopold maneuver called as? What is this Leopold maneuver called as? So this Leopold maneuver is called as fundal grip. It's also called as Leopold first maneuver. Leopold first maneuver. So Leopold first maneuver or the fundal grip mein, you hold the baby at the fundus and then you try to you try to palpate the fundus of the fetus. You try to palpate the fundus of the uterus. So fundal grip or Leopold first maneuver में, you try to feel what is present in the fundus of the uterus, right? So if you feel there is a soft, broad, irregular structure, then it is a fetal buttock. If you feel there is a hard, curved, globular, and ballotable, then it is the fetal head. So if you feel there's a soft, broad, irregular structure, it is a fetal buttock. If you feel there's a hard, curved, globular structure, globular and ballotable, then it is a fetal head. Second Leopold maneuver is also called as lateral grip or the umbilical grip. Yes. So if you feel a smooth curvilinear resistance, then it is a fetal back. If you feel there are multiple knob-like structures, then it is the fetal limbs. Smooth curvilinear resistance is the fetal back. If you feel there is a smooth curvilinear resistance, it is a fetal limbs. This will tell us what side we have the fetal heart rate. What is the side where we have the fetal heart rate? Okay. This is called Paulick's grip. Paulick's grip helps us to understand whether the presenting part is engaged or not engaged. Presenting part is engaged or not engaged. If presenting part is ballotable, not engaged. Presenting part is not ballotable, then it is engaged. If both, this Leopold fourth maneuver confirms the third maneuver. If both hands are converging, then not engaged. If both hands are diverging, then it is engaged. Okay. A pregnant lady was admitted for pregnancy-induced hypertension for monitoring and bed rest. In supine position, In supine position, which of the following is a complication of the below representation? So what is this? What is happening in this picture? Abdominal aorta syndrome, supine vena cava syndrome, superior vena cava syndrome, ascending aorta syndrome. Yes. So this is compressing the IV. Yes, inferior vena cava. So this is nothing but the supine vena cava syndrome. Is it supine? It is not superior vena cava syndrome. It is not superior vena cava which is getting uh, compressed. It is the inferior vena cava which is getting compressed on lying down supine. So it's called supine hypotension syndrome or supine vena cava syndrome. In the pelvis, most important is this anteroposterior diameter of the inlet. So from down to up, there are three main anteroposterior diameters of the inlet, guys. So you can remember that them as dot. So diagonal conjugate, obstetric conjugate, and true conjugate. Diagonal conjugate, obstetric conjugate, true conjugate. I remember them from below upwards dot. So what is diagonal conjugate? From the lower border of pubic symphysis to sacral promontory. Diagonal conjugate is the only which is measurable. Diagonal conjugate is 12 centimeters. Diagonal conjugate minus 1.5 centimeter will give you obstetric conjugate, which is around 10.5 centimeters. True conjugate is 11 centimeters. So from the posterior surface of pubic symphysis to sacral promontory, it is called as obstetric conjugate. From the upper border of pubic symphysis to sacral promontory, that is called true conjugate. So how am I remembering this? I'm remembering it from below upwards, dot, diagonal conjugate, obstetric conjugate, and true conjugate. See, this is called plane of greatest pelvic dimension. This is plane of least pelvic dimension. Plane of least pelvic dimension passes laterally through ischial spines. What is the space between plane of greatest pelvic dimension and least pelvic dimension called as? This has been asked as a question, guys. What do you call this as? So this is called as mid pelvis. This is called as mid pelvis. There are four types of pelvis based on Caldwell and Molloy classification. There are four types of pelvis. So first is a gynecoid pelvis, which is a round pelvis. Then we have, see this, from anterior to posterior is oval, anthropoid. This is heart shaped. This is called android. This is transversely oval. This is called platypelloid. Gynecoid is the most common. Platypelloid is the least common. Gynecoid is good pelvis. Android is the worst pelvis. Gynecoid will have side walls parallel. Ischial spines not prominent. Subpubic angle more than 85 degrees. Anthropoid is anteroposteriorly oval. Side walls are parallel here. Ischial spines can be plus or minus prominent. Are plus or minus prominent. Subpubic angle is normal, more than 85. Here, This is android. Side walls are convergent. Android में ischial spines are prominent. Side walls are divergent. Ischial spines are not prominent. Anthropoid favors direct OP position. Anthropoid favors direct OP position. Face to pubis delivery. This favors OP position and deep transverse arrest. Android will favor deep transverse arrest and OP position. Platypelloid favors face presentation and asynclitism. And asynclitism. Okay. So next, what are the cardinal movements of labor? The sequence of cardinal movements of labor is important, guys. First, the head will engage inside, so engagement. Then baby's head will go on going down, descent. With respect to the ischial spine, we speak about the descent, guys. So descent, when the fetal head touches the ischial spine, it is called zero station. Once it touches the levator ani muscle, it will undergo further flexion. Then it will rotate. That's called internal rotation. Crowning. Delivery of the fetal head is by extension. Restitution and external rotation are considered as the same point. Last is expulsion of the fetus. In this, crowning and restitution are not included in all cardinal movements. Actually, there are 7 principal cardinal movements. Extra are this crowning and restitution. Okay? So this sequence of cardinal movements should be known to you. The sequence of cardinal movements should be known to you. So it is engagement, descent, flexion, internal rotation, crowning, extension, restitution, external rotation, and expulsion of the fetus. See, the transverse engaging diameter for all is same, but the anteroposterior engaging diameter keeps changing. The transverse engaging diameter is biparietal diameter. The largest transverse diameter of the fetal skull when passes the pelvic brim, it's called engagement. So the largest transverse diameter is biparietal diameter. So this is a complete flexion. Complete flexion में the anteroposterior engaging diameter is suboccipitobregmatic. This is a posture of crying, no? So suboccipitobregmatic, which is considered to be 9.5 centimeters. This boy is crying so much that he's decided to go to military office. So second one, if you're seeing, this is the deflex position, or who will see straight? Military people. So military position. Military position में it is occipitofrontal. Occipitofrontal, it is 12 centimeters. So how do I remember? Military office at 12. Military office at 12. Okay. Next is partial extension. Partial extension में the presenting part is mainly bro. Mentovertical, which is 14 centimeters. The entire pelvis maximum diameter is 13. So bro will never come out from the pelvis. So for bro, the mode of delivery will be always LSCS. Complete extension is face. Face It will be submentobregmatic. Again, it is 9.5 centimeters. Again, it is 9.5 centimeters. So how do I ask the students to remember is, so this boy is crying, sob. He cried so much that he decided to go to military office at 12. So military occipitofrontal 12 centimeters. And he tells his friend, but his friend comes and tells him, bro, move, it's 14th Feb. Go celebrate with your girlfriend. Bro, move, mentovertical, 14 centimeters. But why is he's not celebrating Valentine's Day and why he's going with not going with his girlfriend is because his girlfriend called him Sambar face. So the last one you can remember it as Sambar. Sambar. Submentobregmatic. Submentobregmatic. Sai, what are you asking? NEET PG paper? Difficult ga untada. How do you want it to be? Difficult or easy or medium? Medium ga untadi. So better than thinking that how will be the paper, I feel you should think I should get my dream college and dream rank irrespective of how is the paper, right? Okay, I'll write only black. I'm sorry. No, actually, this is not white. It is green. Okay, I think green is getting mixed. I'm very sorry. Wait. Bro, mentovertical 14 centimeters LSCS. Last I wrote face submentobregmatic 9.5 centimeters. Face may will labor happen? See, obstetrics and gynecology, so it will be easy. Yeah. Other subjects I will not tell, but OBG will be moderate to easy only. OBG will be moderate to easy only. To be frank, from this just one session and tomorrow's session, you can actually answer wonderfully. Like if you have almost like 25 questions, 20 to aram so you can answer. So one or two points which I'm not covering are this polyhydramnios. So causes of poly and oligo that you look into. Okay. Right. Now, yeah, face may, if it is mento anterior, then mode of delivery is vaginal. But if it is mento posterior, then you'll go for LSCS. Okay. Right. Now, coming to the stages of labor. We all know that we have 4 stages of labor. Don't think about what is a competition. It really doesn't matter, right? So when you concentrate only on your journey, I do understand if I just tell this, it's not fair enough, but I always give this example. So when we are born, there were millions of sperms which are competing with one ovum. So you are among that one sperm which has gone and fertilized the ovum, and you are born, right? So there are millions who couldn't win. So that's all. We are winners, and yes, concentrate only on your movement. Don't bother about what's happening with others. So when you're focused about what you want to have and what you will get, really doesn't matter, right? Okay, now I think this requires little more, attention to understand the labor hours. So I think tomorrow fresh, I'll start with the labor hours, guys. Tomorrow fresh, I'll start with the labor hours. So labor ka normal duration and all. Tomorrow first I'll start. I'll start little early tomorrow so that we can discuss about this labor and all. And then we'll go for the gynec, right? So gynec also I'll discuss in this crisp manner and I'll finish the gynec. right? So now go sleep well, don't think of anything, and enjoy well. Okay. A small story before I end, actually, which I used to personally love. So there's one lady from Maharashtra. Both husband and wife were farmers, and one day they were completely like just working on daily wages and all. One day, husband had a mild cardiac pain or something like that. So she took that husband to the hospital. When she took to the hospital, they told he requires stunt and all, which requires money. So they work on daily wages. They don't have the money. They told that for the procedure they require around 7,000 and all. But this lady absolutely didn't have any money for that provision. Okay. Now she didn't really know what to do. But when you're very strong and you want to do something good, if your belief is very strong, definitely you will find a way. Universe itself will give you the way. So when they went out, they were eating some samosa. On that paper, it was written that there is a marathon which is going on in their city, and whoever wins that marathon will get a prize money, which is exactly equivalent to the money which she is requiring. Okay, right? So what this lady did, she's around 63 years. This this lady went for the marathon. This lady went for the marathon, and what she did, she asked that whether she can participate in the marathon because she was so desperate they allowed her to run the marathon. Now, this lady not only ran the marathon, she won the marathon. Now, why do I like this story is she won the prize money and she could save her husband. So what I love about this story is that lady who is old enough, she was not prepared for the marathon. She didn't prepare for years together, or she didn't prepare at all. She didn't have proper shoes. She didn't have proper attire. There were so many competing with her, but still she won. Why? The only thing which made her win is her desperation to win. So sometimes, more than everything, how many are competing with us? Are we ready for this? How is our preparation? Our desperation is important. We are desperate to win this. It will automatically, the path will open for you. And the desperation should be positive. And when you have that positive desperation, automatically all paths will open up. There's one saying, no, by Shahrukh Khan, अगर किसी चीज को अगर आप पूरी शिद्दत से मांगो, पूरी कायनात आपको वो दिला देता है. So, when you are very desperate, automatically all doors open up and it happens. So just be positive. Enjoy your day. I'll see you all tomorrow. Thank you so much, guys. Good night. Sweet dreams. So tomorrow I will start around 6 p.m. itself because so I will just discuss with them and I'll start around 6 p.m. so that we can cover this part also. Okay. Right. So I'm ending it for today, guys. Thank you so much, Bunny. Thank you all.